Good afternoon, everyone. Welcome to this star-studded cast that we have here today. Welcome to our session on harnessing the power of data. We're really glad that you are here. And if you're standing at the door wondering if this is a great session, the answer is absolutely yes. We can't talk about digital and AI as we are doing in this PMAC conference this year without talking about data. We know that health data are approximately 30% of the data in the world. We know that its compound annual growth rate is 36%, which is the highest of any industry. Yet we also know, there are various estimates, but that only around 3 to 5% of this data actually gets used to improve health outcomes. Health data, as it turns out, between 50 to 60% of it mostly gets used to process insurance claims or for administrative reporting purposes. Surely we can do better, and that is what we will uncover and discuss in our session this afternoon. We will look at the value of public health data from all angles, how it is generated, how it is integrated, and how it is used through practical case examples. To do so, let me introduce you to our panelists. Our first panelist is Dr. Bunchai. Now, I will say that when I first got involved in the world of health informatics, Dr. Bunchai's name and Dr. Bunchai's papers and the work that Thailand had done on developing terminology registries is some of the first health informatics work that was out there. So I'm really honored to share the stage with Dr. Bunchai today. At the moment, he's a lecturer at the Department of Clinical Epidemiology at the Faculty of Medicine at the Mahidol University here in Thailand. He is also the chair, and I could say the father, if that's okay, of the Asian e-health informatics network, and those of us who've worked in health information inevitably have come across his name. Our second panelist is Dr. Peter Ross, and Dr. Peter is equally famous. Those of us who have heard of Estonia's immense progress that they've made with health information. In fact, many will say that Estonia has one of the 3 best health information systems in the world. Dr. Ross has been a key part to making that happen. Right now, he is Professor of eHealth and Head of eMedLab at the Tallinn University of Technology in Estonia. Our third panelist is Annie Hardy. Annie is both a medical doctor and an AI doctor. She has appointments in 3 places. I don't know Annie as long, so I can't yet speak about her storied history, but you'll get there. She leads the Laboratory for Intelligent Global Health and Humanitarian Response Technologies, or LIFE. She is based jointly in the US at the Harvard-John School of Public Health, in Switzerland at EPFL, and Rwanda at the Carnegie Mellon University of Africa. Annie, welcome to the panel today. And then we also have Kara Sewok. I was very interested when I first met Kara, which was just earlier today. I heard that she works at the Boston Children's Hospital and immediately thought that her application is on clinical applications of using AI in a hospital setting. But I learned that in fact she works in a unit on computational epidemiology. And what they do is to use novel data sources to predict infectious diseases. And you will learn a lot more from Kara about that today. She's the Senior Manager of the Innovation and Digital Health Accelerator at the Boston Children's Hospital. Let me tell you a little bit about how the session this afternoon is going to unfold. We will have a combination of discussions and presentations, but we've tried really hard to avoid the format where someone stands at a podium, everybody else listens, and then we sit down and we move to the next speaker. So everyone will present whilst seated, and we will combine discussion with presentation. None of us have tried this format before, so we hope you are patient with us in case there's the odd glitch or two, but we think it will make for an interactive and interesting discussion. In having the discussion this afternoon, we will have there are three blocks or three themes in our discussion. The first theme is about the development or creation of public health data. The second is about the integration and management of public health data. And the third, as you can imagine, is about the use of that data. We will look at use cases as well as challenges and what it is that we still need to do to move forward. So with that, please also keep in mind that we will have Q&A, or the first part of our discussion will be for 90 minutes. And in the last half an hour of the session this afternoon, we will also have a audience Q&A session. So please tee up your questions so that you can make the panelists work for their money by asking them some challenging questions this afternoon.
Oh, if only you got paid.
So we will get started. And the very first question I'm going to ask Dr. Bunchai, reflecting on the foundational work that needs to be done in terms of public health data, how is public health data typically created at a national level?
Okay, thank you, Marilis. And it seemed like talking to friends, a lot of familiar and friends, and we we would like to have your more kind of the question and discussion. We start with the first. The question is about what is the health or public health data and how it's generated and how it developed. I think most of us are people who work in the health and medicine or some kind of related to health, even financing to support the healthcare. I think even now we still familiar with the paper record, right? And the paper record can be at the transaction, at the medical record, and also at mostly in the survey or in the reporting system, the red one. And you can see that gradually many of the health and public health data are generated by the electronic. Many countries, include Thailand and also especially in Estonia, that are digitalized and become the data at the point of care, and also the data in a higher level for the health management information system or electronic. So you can see that there is a variety of the data, not just for the healthcare, but also for the report, for the survey, and also like related to the financing side. And usually when we talking about the public health data, to me, I think we talking about the how we gonna talking about the available health data, health related data that can be used for many functions. So this is kind of the general of the how we develop or the source of the public health and health data come from.
Thanks very much, Dr. Bunchai. Peter, what do you think? Is this your experience as well?
Absolutely. Well, starting with digitalization and thinking that digital health will solve all the issues, then we have been disappointed very soon. Dr. Bunchai also emphasized that there is some medical records, there are statistical data, there are financial data, and they actually stem from different sources in the paper world. What we want now to do in the shared world is that capture once and use unlimited times, and this is a really challenge. So I would like to share our experience learning how we have discovered the different data subdomains and also the challenges. Let's start from primary use of data and secondary use of data. This is very important to distinguish it from the very beginning. Why? Because primary users of data who are medical workers, they need data now and quickly. While secondary users of data, they have time, but they need high quality data. If we look from the three perspectives that what is the content and main of the data and who are main users, then who actually regulates the capture of this data, and then the tools what we use, then we will get quite complicated picture. So let's start from the primary use. I'm a radiologist, I'm a physician, so I'm quite well aware that if IT people won't develop the system which is quite intuitive and quick, then they are my biggest enemies. Usually these information systems like electronic medical records, different hospital information systems, they are regulated by the institution itself or Ministry of Health or digital health departments. And they are for operational data, like radiology, laboratory, cardiology. Each specialty has its own purposes and own demands for the information system. And as we discussed, that the information system must be really user-friendly, and data is time critical. So no too much attention on the data quality, because if patient is bleeding, we have to act, not to click SNOMED CT classifier. Very easy, very straightforward. But things comes complicated when we would like to reuse this data, so secondary use of data. And then we have several customers, data users. First, hospital managers. They are interested about the BI, performance indicators, but still they work in the circumstances of hospital information system. And we know from the different studies that actually hospital information system or electronic medical record is making patient appointment longer, because it's less convenient for the physician or nurse to use electronic medical record than paper for the really quick data capture. And this is true. So, and why this has been, one of the reasons obviously is that if you think who pays for the hospital information system, it's not physician, they are hospital heads, and they would like to have high quality BI to know where money goes and where are resources. So this is like a first dilemma. Then we come with public health data or population data and researchers. They are interested not about this operational data, but much more aggregated data, disease prevalence, health indicators. And this data capture is regulated by now different institutions. It's not anymore maybe hospital or Ministry of Health, but it's also statistics department of the country or so on. Then we have, of course, payers, and the claims management, it's usually also included in the electronic medical record or hospital information system. But again, the content of the data is different. It's the pace of the capture should be quite quick because we want to get money reimbursed quickly, but still the content is different. It's again diagnosis, like the number of lab test results and so on, for what insurance pays. Also quality indicators. And again, in different countries, depends on the country, it's regulated by different institutions. So we have more and more entities what are data consumers and regulate the data capture, but we as data providers, medical doctors, our aim is totally different. Then politicians, They need information about budgeting, health services planning, KPIs, reports. And finally, let's not forget industry, like pharmacy, digital health industry. They also need data. But to sum up this slide, then the secondary users of data, they are much more interested about the data quality. The user experience is not so important. So we see here really big tension. We see that actually those who oblige to capture data, their demands are for the really user-friendly environment. And those who are using data then secondarily, they would like to have aggregated data, and they have much more time to get this data. So with this tension, I would like to hand over now.
Thanks very much, Peter. You know, what you said really reminded me of what I think are some pretty scary statistics. In the United States, a primary care doctor spends on average 4 hours a day in an EHR during the workday, and an additional 2.8 hours of pajama time at night, just catching up on EHR capture. The average an emergency room doctor, on average, clicks an EHR 4,000 times during one shift. I think as it describes this asymmetry that you've just described really well. So we've started to discuss. Go ahead.
Yeah, if I may reflect on this also, this is very, very valid point that here actually we see clear opportunities of AI. Chatbots to capture the data, to put the captured data into the standardized format, structure it. Yeah. This is one, and second is the person, that why I as a medical doctor should like be a typewriter. Why not give a person this duty to fill in the form before seeing highly paid specialists?
Annie, what do you think about this idea about using AI to be a medical scribe or a chatbot or referral forms or respond to patient messages in a doctor's email inbox? What do you think?
Well, I'm an AI researcher, so obviously my answer already. I think it's great. But I'd like to also just reflect on some of the questions that were answered here, where you were speaking about problems about, like standardizing data, managing data, collecting data, spending time in EHR until doctors have burned out. And as a global health researcher and making AI for global health settings, I'd say that it's not about data management or standardization, it's about data existence. Everyone, like here, I feel that people saying, we've got too much data, we need to use it. For us, we don't have any data. And especially, you don't have any data in the places that need it the most. The places where you actually need evidence to make decisions because you don't have the resources to fall back on. You have no safety nets, no processes. So you have to have really, really good predictions if you want to do proper medicine in low resource settings. You don't have doctors who have the knowledge. So where can you get that? You need to represent it in some way. So for us, if I even go to, I've got a slide just to show over here, I suppose, where we must remember what paper records look like, right? And so I put this over here just to kind of show you, just remind you the mess of a paper record, okay? And this is in one of the hospitals that I work in, volunteer in South Africa, and it's very organized. But in another one where I was in just a few months ago, I wanted to go and see the paper records, right? So I go inside, I'm just curious, and I tried to go in, and all of a sudden someone stops me and they go, don't go in there. I was like, oh, this is really good data security standards. I'm very impressed. I'm like, is this part of your policy? And he says, no, there's snakes living in there, right? It was so neglected that it had actually become a vivarium, right? They had made a hole in like the window, and they would put the records in the hole, and it would just and then it filled up, and then they made a hole higher up, right? So this is how data is really managed, right? And even if we did get that data, right? So we put in snake wranglers, we go and get the data, right? And we go and take all these things out, and we go and photocopy them, and we get millions of dollars, and we digitize it. What's in there? What's in there? If you do not have the gold standards, you don't know what the patient actually had. Who is diagnosing these patients at the moment? Who's managing them? So even the data that we do collect, we often can't trust, right? And I think that's a really important point. So where do we get this data? Because if we're making AI systems, which would be amazing for these settings, right? There's nothing more valuable in the world. If you're a doctor, you know this. Who's a doctor here? I'm sure there must be some, yeah. You know, right? That the most important thing that you can possibly give a patient, and that's what we are trained to do, is information. But you just have to give them the right information at the right time in the right place. So I think it's really important that we respect what information is, where it's coming from. And in AI, all an AI tool is data that is compressed, and it's a conversational interface when it's a chatbot to that data. So if you don't have data and it looks like this, then what people have been doing recently, they go, well, I'm going to go and collect data then. Okay, I see your problem, I'm going to go collect data, and I'm going to have all of these different efforts in different, maybe in different like places where we are working. We're going to have randomized control trials, observational cohort studies, and everywhere. And then we're going to have a whole lot of fragmented data that we hope that we can standardize. And you have a whole lot of then fragmented AI, right? And then what happens is exactly what's been happening in previously when we're dealing with like e-health tools. We just have this absolute pollution of solutions that are all too small because they don't align, right? And so you've got these fragmented apps that are everywhere, and you don't know which one to use, and the ones that are not, like, they don't have enough data, and then there's no statistical relevance for them, so then they can't be actually validated or used. And our phones, my goodness, if you're a doctor and you have apps on your phone for different places, you have no idea. There's just this pollution of apps. You don't know which one is validated, which one is up to date. Do you have to download it again? Which one should you use? And so this is a huge problem, because if we fragment our data, we fragment our solutions, right? And so it's important that we can now, with this new kind of wave of AI, where we're speaking about chatbots, these are called also, I'm sure you've heard the term foundation models, right? They're foundational because they kind of consolidate information from a whole lot of different places, right? So we can use disparate sources of information as long as they are representative enough. But they'll never be representative enough, ever. It's never going to happen. So instead of waiting for that, and by the way, how long do those randomized control trials take? Even if we tried today, we go and say, okay, fine, I'm going to launch some randomized control trial. Maybe 3 years, 5 years, and then you have some data transfer agreements, and then someone goes on holiday, and then it's Christmas, and then it's Easter, and then there's no more holidays, and oh, that didn't get signed, and then 10 years pass, and then you have the data, and then what? People are using ChatGPT now, right now. They're using it in their systems, wherever they are, they can ask questions, and it's unvalidated. So we need to be able to do something now, and rather respect data, not as historical data that we are managing, right, in places that will never have an EHR sometimes, rather to accept that those foundation models will never be perfect. Even if we use our existing data coming from PubMed, for example, less than 3% of PubMed represents the African continent. So we'll never have a perfect model. So rather accept that we'll never have perfect data and take an imperfect model. And then I see that there's a little bit of a strange you can't really see the animation, but that's what I'm trying to say, is nudge it, right? And so you can kind of, instead of making this model that's perfect for your setting, rather take that model and use it, right? And collect data while you are using the model, and you tell people, hey, this model is no good. It's only half good. And now it's up to you and your responsibility to use it and nudge it until you get something that's adapted to your setting. Yeah.
Excellent. I think that's a great way to think about health data, not from the clinical perspective or the hospital management perspective, but from a technology perspective, right? Dr. Bunchai, what do you think about these challenges in data?
I think I like Annie mentioned about the consumer data. This is we sometimes we said, oh, when you go to the administrator or policymaker, they said, you already had a lot of data, why don't you use the data, right? And it seemed to many people that there is a lot of, huge of data, big data in health, but have not been used. But actually, the huge data is maybe a garbage. It's not standardized, it cannot be aggregate, it cannot be used, even create a model, something like that. But I think it depends on the perspective. If you work at the Africa, like any work with the Mediton AI model, it seems like even in the village, they don't even have the medical record. And even they have the electronic medical record, there is snake in the medical record room that cannot be get the data into the system. But in many countries, the medical record is both in paper and the electronic, and countries like Thailand and Estonia like this one. And so I think it is good that we're talking about there is variety of the perspective of the data, and the challenge of the data is not just the source, but it's all the data itself. I really like the fragmentation that you said. It's the challenge in
It's a mic, sorry.
here in many system, right? You can see that even in healthcare, hospital data, or in the report, there is no standardized. Even work, there is no standard, so always fragmented. I think everyone in this room are feeling your healthcare record never go to from one clinic to the hospital. You don't have the whole line at electronic medical record. Not like the Estonia that they had developed for 2-3 decades, and they have the digitalized, and then they can integrate it later. And not just that, many countries include Thailand and also the lower middle income country. People are not we also not have the capacity of people to do the digital health and the standard. The first thing is that data is not standardized, so they cannot integrate that data. I think this is the one that is the challenge of the getting good quality data, right?
So I know we haven't yet asked you, Kara, for your contributions. I wonder if you could tell us a little bit about, or share your reflections on what Dr. Boonchai just mentioned about data not being in a standard format, because I would imagine that if you're working with novel data sources, you are working with the most unstructured data that there is. Do you want to just tell us a little bit about what you guys are doing and also your reflections here?
Yeah, well, before I get into that, I did want to reflect on just the fragmentation of data in the United States. As a high-resource country, we still face that large issue. Specifically in Boston, at Boston Children's Hospital, a large issue we have is with the mother-infant data operability. So really trying to understand how do infants who are born in our hospital, how does that connect to their mother data? And there's just no way to connect those records in an easy way. And so that is a large challenge that we've had to face with. In terms of the novel data that we collect in terms of surveillance, it's largely unstructured. There's, in a technology atmosphere, there's a desire and drive to structure data. It's the best way to input and analyze it. But in the types of data that we collect, it's very difficult to do that. And it lacks a lot of the contextualization that we need in terms of trying to really understand what is actually happening here. So I think even across the board, from a clinical setting to even the more global public health surveillance mechanisms, it's super reflective.
And can I add on that, because I find this the fragmentation is a problem, but then often people resolve the fragmentation by going, well, let's all share data together, right, and put it in one big central pot, and then we'll work on it there, and then we can centralize it there and we standardize it there. That's been how everyone has been handling it. But this is really unfair. It's really unfair because who do we share our data to, right? Data is money. Data is an asset. data is difficult to collect and extremely difficult to standardize and even more difficult to make private. So what you're doing, especially from, as I said, I'm here on behalf of the low resource settings, you're making people responsible for making their data private, making them take the time to collect it, and then they have to just give it up. And they give it up where? To the higher resource setting. It's unfair, right? And then they lose all of that ownership so that someone can make a model that still will not represent them, because they'll get that data and they'll go, oh, well, the setting's so different, so I'm just going to generalize my model to the data that is mostly shared. So it's so disincentivizing for low resource settings to share their data. They don't share it, and when they do, they still are drowned out and diluted by what is mostly shared. This is unfair. And so I don't know if anyone here in the audience has heard about federated learning. It's a bit of a buzzword. Do people know it, right? Who doesn't know it? Who wants to? All right, everyone knows it, right? Great. Well then, so it's a buzzword for a reason, and everyone does know it for a reason, because it is extremely helpful. And we shouldn't just copy and paste the central setting. There are other options. We can, instead of copy pasting the data to the source of the model, we can copy the model to the source of the data, and then decentralize the learning of models so that people can retain their ownership. And I think that that's also something that we can do. And with the larger models that we have, the problem of interoperability can be partly solved. So if someone is collecting temperature with one device in one place and another device in another, if you have a model that's big enough, the connections of the temperature to other things can be found out almost for free, right? Even though you have shifts, you can still figure that out because you've got a large enough model that can represent the shifts in data between different settings and still preserve the predictive capacity of the data. So our understanding of sharing data, centralizing it, defragmenting it, as well as making it more interoperable are also changing with the changing technologies.
And I think that's an excellent segue into the second part of our discussion today, which is on data integration and management. As you said, just as there are federated learning approaches, we also know, and I think India was really the first country that showed this at scale, there are also federated architecture approaches, right? In India, data is not kept separate, it's centrally. And it's not kept centrally because the government said, we don't want that responsibility, because if the data is all in one place, how do we keep that secure ourselves? So the data stays in its place of origin, and data are shared through patient consent. So combining such federated architecture approaches with federated learning approaches, I think we're really starting to see how the game is changing. But Peter, I feel like day in and day out, you teach at a university about data integration and management. What are the critical success factors for thinking about how to best integrate and manage public health data? You want to share your thoughts with us?
Yeah, sure. A lot have been discussed here already, so I have not much left, but I do my best. And before that, I would like to reflect this consent idea. I think this is also the way to go. This is a brilliant idea to give power to share the data for the person, instead of collecting it in some of the databases which is owned by the government or global companies. So this is definitely the way we should go. But from the Estonian perspective, and based on our 20 years experience of digital health data platform and data sharing, then I share with you current situation and what we would like to achieve in the near future. So as we have discussed that the data is generated by the usually by the healthcare professionals or then person him or herself, and it goes to the electronic medical record, and if country is happy to have an electronic health record where the data from different medical records is shared, then you have great data set of mostly medical data, not health data. And then you have these hospital managers, insurance, population health researchers, and each of them are collecting their data by their own data streams. And this is how the situation is in most of the world. And then we, of course, each data consumer has their own databases. We get the fragmented architecture there. And in case of research or claims management, then you even use hundreds of people to clean this data, to encode the data, and then we have high quality data. So it's not duplication, it's multiple entry of the data, and the result might be good in some times, but it's still very, very resource consuming. In the better case, you can retrieve from electronic medical record also hospital management data, claims data, maybe some public health data also. But as we saw, also randomized clinical trials by pharma companies, they are done usually using different, totally separate data streams and data cleaning. So it takes time, it's long, it doesn't make much sense. So where we see the solution is that we have to use, and I know, Mariana, was this your idea also, that we need to have more universal data models. We need to collect data and then start to use them, rather than have separate data models and then try somehow to merge this data. So data harmonization, like terminology, classifier, catalogs, they should be applied already in the phase of data capture, not when the data is there in the silos and so on. And if we do this way, then we can create unlimited virtual registries, or even unlimited number of digital health services. So advance from the digital health 1.0 to 3.0, and have the ecosystem which is customer oriented rather than the data providers oriented.
And I would like to also just pose like a more how this could evolve in the future, right? With AI and large language models, and as the models get larger and larger and more complex, and they can also reflect better the complexity of our real data. And who are we to say that we have all of the terminology for every single kind of person, right? Why do we have to categorize people in certain race categories that maybe they don't even agree on? Who says that those are the categories that are correct? Some people, don't even agree with basic things that we put as binary in our categories, such as sex, which is true. It is a spectrum. So how can we really represent the diversity, the growing granularity that people are demanding of their health data, and to actually reflect data not as discrete categories later when it gets more and more complex, but to allow the data to speak for itself, to categorize itself, and to recognize data as a model. And this is when we are taking our models, is what we're doing as well. We're making large language models that represent general contexts, but by definition, generalization is unfair to underrepresented contexts. So we try to further specialize the models to make them like nudged to the right environments, to make sure that they are representing smaller and smaller populations. And those composites, massive black boxes that we can have a conversation with, are representations of data. And it's that we have to manage in the future. Data that we can never understand because it's too big, but representing certain populations in a way that we can't understand. And as long as we collect the data in a way that is systematic, we hope that at least the models are representing that population as well. And moving away from things that we can name to conversations that we can have with our data. So who manages that? And I think that's something that we're going toward, and we have to figure out how to move from things that we can name to things that to clusters to collecting things that we name, to rather getting clusters back that we have to name.
No,
for us to
it's
understand it.
more of an inductive than a deductive
Yes.
approach to how we
Yeah.
think about data, right?
Mhm.
I think another piece to, and it really comes into this bottom piece about digital health services. I would like to think that in future we would think of and consider patients' access to their own health data as a foundational digital health service. It just still is so surprising to me that all of us, I almost want to guarantee that every one of us in this room has on our phones an app with our banking data. We would be livid if the things we bought at shop 1 appears on our list of expenses and the things we bought at shop 2 do not appear. Well, maybe we'll be relieved, but we will be falsely relieved if not all our expenses appear on our phone. And yet somehow we have all said to ourselves, and we are all okay with the fact that we do not have that kind of access to our health data. Or when we do, living in the United States, I've learned this in the last decade, is just how hard it is when you have a different patient portal for every physician that you visit. There are at least 9 versions of me in the medical system in the United States, because whether you go to your ophthalmologist or your dentist, you fill out a new patient portal every time. And I am sometimes lazy. I do not remember the surgery I had on my leg when I was 11, and I do not fill it in my dentist patient portal because I figure, how could that be relevant, right? But I think we really have, this is a mindset change where I think we all have to demand, and people will say, but this is my health data. I need to have access to it. Which brings us, I think, to the second part of this conversation, which is over and above the fact that we don't yet have access to all our data, that the structure and even conceptually how we think about what constitutes health data is changing. Having been in the space for so long, Dr. Bunchai, what do you think about what are some of the pitfalls that countries and folks who are here today that they should anticipate, avoid, etc.? What are your thoughts?
To me, like health data, public health data is all over the place. The fragmentation, the silo that we already recognize in the system, right? To me, I think that we have many silo data because of there is so many application and system, and it seems like the policy maker, the people who have resources would like to use the data and assume that only data is in hospital are on the same data model or the data model or the structure, but it is not true. So to me, I think there is so many components. In our Asia eHealth Information Network, we face this from working with friends in many countries, and we found out that the foundation to generate and to integrate data haven't been kind of laid out for countries, and we identify that it is not just the technical part. It is up to the policy part, the political view. If the country don't have the governance system that can be talking to the Ministry of Finance, Ministry of Health, and Ministry of ICT to work together to come up to see the same health data system that can be served like the long life health record or even the consumer to get that. That is very hard. And this is the most harder thing. And we think that the governance is the first success factor that the foundation that the country should have. Another thing is that, like we discussed about the centralized or federate or decentralized, how to share data, not to share data. Who is the owner of the data. So the blueprint or the architecture of how we're gonna kind of agree upon what we should do, like you said, India, there is 1,800 millions people. Many provinces very big. So it is not possible to kind of centralize it. This is also related to the privacy and confidentiality. I think Peter can share more about the Estonian experience on thinking about a central and then later federated. That is need the blueprint or the architecture. The third success factor is that people have to be know the people, not just the user, but also the developer and not just the private, but not just the public of the private. They have to work together and be literate to know how to develop, how to use, and how to be prevent and security and privacy. So people is very important to make people work together and be knowledge about that. And the last one, if we don't have standard to like in the level of the data, the meaning of the term and also the format, it is not possible to integrate that data. So if we have these four foundations, I believe that whatever system or ever application that you want to use to collect, to use the data, it will be more easier and more possible. This is theory, but the real world is very difficult. People don't talk, and the importance of the interoperability is people coming to talk. It is not the technical. The technical can be addressed, and on the past 15 years that we work with country in Asia Pacific, we found that the people interoperability is more important than the data and technical interoperability.
This is true. I know from just the work that and many of the requests that we receive from client countries, the bottom one on standards, which seems to be such a foundational piece. So many countries are still struggling with that. And I'm thinking, Annie, about your point about, I think you really challenged the thinking about, do we really need standards, right? In the future, if we have these massive amounts of data, instead of trying to develop standards and then collect the data based on the standards, we would rather dynamically develop categories of data based on the corpus of data available in many places, which is a very different way to look at it. Dr. Boonsha,
I wanted to come back to the one thing that you said, which I thought was interesting, because it's again one of those kind of stories that are different in low and high resource settings about people's expectations. So you said, that we need a mindset change for people to want to have their own data. But in higher resource settings, it's always been a centralized hospital or a doctor that's been the custodian of the data. And in lower resource settings, where I'm working in Cameroon, in South Africa, and other places in the rural areas, patients come to the hospital with a little book. Yeah, they've got their little book. Yeah. And that book can be anything. I've had all sorts of stuff. I've had, they bring their children's coloring in book, but in there, that's where I have to write their prescriptions. That's where I have to write everything. It's their health book, right? And I've had to write really serious things around this half-colored in dinosaur. You know what I mean? So there's an expectation. They take that book home and it's theirs. Yeah. And so there's an expectation actually in some places, which is really promising, that this is their data and they own it. And when you have to actually collect data in these settings, it's really important to do community engagement because they want that data back. Yeah. And I think that's really nice for a leapfrogging moment in lower resource settings where there is that expectation. So let's make sure that we deliver on it from the beginning. We don't need to learn how to use the fax machine in order to use a mobile phone, right? So we can actually jump over centralized systems to start with decentralized systems that empower the patient from the beginning.
And linked to that, I think we can also use large language models to if we think about the data in an EHR, I know in the US, right, when you have a laboratory test done, you would get your test results these days before your appointment with the doctor to discuss the results with you. And if you're not an informed patient, or you're somewhat of an anxious patient, or it's a fairly serious diagnosis, that can cause significant health-related anxiety, right? So can we use large language models to translate, present this information in a way that doesn't contain lots of big medical terminology that can be really scary to a patient and actually prevent them from going to the doctor to understand what these results really mean?
And you know what? You don't need to have patient information in a large language model for it to represent your setting.
Exactly.
You can actually represent your setting using like incidental data, hypothetical data, data from studies, and you can have personal data that you then query the model about. So as long as your model is able to make predictions about information that you give it, and it represents the setting, then you can have a chatbot that represents you and be able to interact with your own data without having to share it as well. So it's about having that doctor that can interpret your information, given your setting. And I think that's a really important use of large language. That's how we are making our large language models. Our large language model, Meditron, is just one of the many, but it's basically just understanding the context and understanding how a certain lab result should be interpreted in a certain setting.
Dr. Bunchai, I asked you about pitfalls, and you discussed the critical success factors, but I don't think you got to the pitfalls. Do you want to share those?
You know, it is the flip side of the coin. The success factor, that is because of we have the challenge that we don't have all of these. We are neglecting foundation. So when you said success factor, it means that you don't have those. Why don't you have those? Because of we assume that we have data. I think I like and comment about, you know, we haven't thinking about the place that even data are not exist because of they don't have healthcare system. They don't have even healthcare system to serve there, and you can see the very close link between providing care, having care, and the data that can be using for that. It's not just for planning, statistics, and business intelligence for the policymaker. And this is a closely linked. But sometimes we said, oh, we just have a medicine for TB, malaria to the people who don't have this. But how do you know that this one already get this medicine and another month they should get another medicine? You have to have record. And that record should have been somewhere in lower middle, very low middle, very low income country. Even the system to handle that record is not there.
I'm surprised we're going to wrap up the second part of our discussion and move on to the interesting part, which is using all these data. I do want to say that in our discussion about data integration in management, I'm surprised no one used the word dashboard, because I think typically when we think about let's use or let's manage, how do we manage all this data? I think for a long time the answer was, well, let's develop some dashboards. And I would also like to think that those of us here in the room would agree that managing data by dashboards or managing a health system through dashboards is probably the most inefficient. I do not want to say useless, because I don't think every dashboard on earth is useless. But I do think that if anything, I hope that one of the things we take away from this conversation today is that once we've done all this work of understanding the data, getting more data, making sure we know what it is and how the links and the standardizations and all these things work, that we will really also push the envelope in doing more than just presenting data in an aggregate or temporal way in a dashboard. I don't know if anyone here has any thoughts about managing data by dashboards, but I did want to ask that question because this might be my pet peeve is how when we think about data management, it's always about the dashboard, but that's not really managing the data yet, right?
Well,
what do you think, Peter?
If I may, yes. It depends how you define dashboard. You could look also from the perspective of the person's dashboard. And if you have in the screen the full overview of patient summary or person summary, this is also dashboard.
Yeah.
I just want to show, I think to display your slide, the primary data use and secondary data use. And those I think that is the key to the to what you said, that dashboard. How can I go to that slide?
They are,
Nearly there, and
they already deleted.
Where? I think the second one.
I promised you at least one glitch, right? Here it is. Mid-panel discussion glitch.
Yeah, that one.
Is it-
Yeah, you can see that to me,
Yeah.
I think there is many perspective of using data, and to me as a clinician and also the people who are looking at the point of care or even take care of the patient, the one at the point of care to decide how to do, decide what to do, what laboratory or what is your history is very important to decide at that point. That is the primary use of the data. But usually, people, the higher level, just assume that you do the routine. You already have those. But actually, it's not served like you said. Information is not user-friendly, right? It's death and life and death. You if you have to come up with 4 hours to key in the EMR, what would be happen? It should be more familiar to them. And if you want to kind of the continuity of care, that the integration is very important. But the policy maker, the people who pay for the healthcare, like the insurance, I want to know what is the indicator of that. How should I plan for that? So you can see the link between money for the insurance and the information system and also the healthcare services, all of linkage to be in the health system. But people always forgot about data. They assume, they take it for granted that it's already in the system, but not. And sometimes even don't have at all.
And in fact, it's just on that last point, it's just that some people go in their entire lives, millions of people, go their entire lives without ever seeing a doctor. And millions of people. So but to build on your point of the dashboards, if you've ever made a dashboard, you know what the primary thing that you have to do is you sit around and you go and you make assumptions. You go, I want to answer this question, and therefore I need this, this, and this, and I need the aggregate of these things over this time, and it's going to give me this answer, right? And there's a lot of like assumptions about what is predictive for a certain thing, right? And that's what you do. You make a set of assumptions that you want to visualize. That's the definition of a dashboard. And so we are kind of trapped in a dashboard to our assumptions. And we're trying to de-bias data and de-bias our assumptions. It's very difficult. We are trapped by thinking that the things that we are collecting and the way that we are collecting them and the way that we are standardizing and naming them actually represent something that is the truth. So even speaking about how we encode race, how we encode what is a person who is disadvantaged, what is a person who has got maybe like a disability that is seen, that's not seen. How do we ensure that we are giving adequate care to XYZ patient, right? And so with larger models and AI models, you're able to do things like what we're doing with the International Committee for the Red Cross, right? They collect an enormous amount of data. It's huge. The International Committee of the Red Cross they aggregate all of the different Red Crosses in the Federation, and they're the central place where the data is coming. So they are like, it's across all these different countries, like maybe 160 countries over 160 years or something like some statistic close to that. And it's so much data that they don't know what to do with it. And it's impossible to standardize it. It would take so long that it would be outdated by the time they would do it. So what do you do? And here is where these larger models can come into play, where we're doing something called talk to your data, right? So it's a chatbot that can then go in and try to figure out what patterns there are, and then find the things that may be predictive of the outcome that you're looking for, and let the data speak to you. Now, is the data going to be correct? No, not all the time, and probably maybe never, but it gives you an indication about what you're trying to look for. We do need to understand it. It's not like we must just allow the chatbots to tell us what's going on. We do need to visualize it, because those chatbots are much more complex than our own brains. And so we need to name things, and they need to make sense. But what are we naming? So I think we'll change the conversation a little bit in terms of a lot of the standardization procedures will stay the same because they make sense. We speak in words, and we want to be able to understand and say, what is the race of this person, or something that resonates with us in our language, right? But we still need to be open to more complex measures of, humans are complex, and we are trying to simplify them into boxes and categories, and to diversify those is an important kind of conversation that I think we'll have when we've got more ability to do so.
And I think also as we have more data that sits outside of clinical care, or the possibility of clinical care, right? If we think about all the determinants of health, depending on whose estimate you believe, only between, I believe, 12 to 20% of determinants of health can be influenced by medical care, right? Whether it's behavioral health, whether it's genomics, whether it's now commercial determinants. We had a session yesterday on digital determinants of health. All these other determinants, that's where the massive amounts of data that sits outside the health sector that may be much more predictive and instructive of both disease progression and treatment. You've started to talk about a solution, but Kara, I want to put the spotlight on Boston Children's Hospital. We'd love to hear about the work you guys have been doing. So over to you as we move into our last session on using the data.
That'd be great. And also to your point too, in terms of data outside of clinical care, where we come from is not just using it as a separate data source, but complementary to more traditional data evaluation. So using it to supplement the interpretations that we're making using clinical care data. And one such example of that, we have a project called Outbreaks Near Me, which is a crowdsourced application where we ask participants in the United States to, on a weekly basis, provide us information around their health and the symptoms that they may be experiencing if they are sick. What we found is that a lot of people who have mild symptoms or moderate symptoms may not seek healthcare. And so in that sense, they're not being captured in more traditional surveillance methodologies within the United States. They're not in the hospital, they're not visiting their primary care, so they don't have the medical records to track the illness that they're experiencing. And so by combining this kind of non-traditional self-reported data, we're able to combine that with more, lab-based driven results to get a better estimate of the burden of disease for a specific illness that we're interested in. And that's specific to respiratory illnesses, because that's the focus that my team works in, but I think it could be applicable to, all sorts of disease that we're interested in. But I'll attempt the clicker. I'll skip ahead to the example that I had that I wanted to showcase to this group. I'll blah, blah, blah on all of these slides, but I did want to highlight one application that we've developed at Boston Children's Hospital in collaboration with Boston University in the United States, called Beacon, which is the Biothreats Emergence Analysis and Communication Network. And this application really started in the global public health surveillance space. So when we think about global public health surveillance, what we're looking at is early alerting of infectious disease events that we're looking at, surveillance of that, so that's the crowdsource methodology, verification and characterization. This is extremely important to contextualize what is actually happening. There's so much data, as we've discussed, out there in the world, but from a subject matter expertise position, it's really important for us to understand, what does it actually mean? How do we interpret it? How do we understand what the risk is, and how should we be responding to it? And then that follows into response. So are there applications we can develop to respond to the events that we're tracking? And so an example of this is a system called Health Map, which is an infectious disease surveillance system that uses natural language processing, NLPs, to scrape the web. So you think of news media, online sources, social media, all of these digital breadcrumbs are extremely useful for us in terms of picking up signals that are happening in the infectious disease space. And so this is a great visualization of an example of, something that's caught in the news, determining what's the disease of interest, where is it happening, how many people are affected, what's the species that's being affected. So these are data points that we can pull out and synthesize and contextualize the outbreak of interest. So where Beacon takes that next step is transforming this kind of aggregated data across the globe and running it through an LLM. So running it through large language models so that we can understand and contextualize what is actually happening, combining all of this different data into a report that's basically summarizing, here's what's happening on the ground. So I'll skip over some text there, but you can see that this visualization shows what the platform looks like in terms of an event newsfeed. So it could tell us where is critical activities happening across the globe. And by providing these early warning signals, it provides public health and ministries of health early detection and earlier response to activities that are happening. So this visualization kind of shows all the different data points that go into this LLM from CDC, Ministries of Health, World Health Organization, online sources like Wikipedia. Google News is a huge source of information for us, and running it through these models to basically output the signals and verification. And one piece to this that I find super fascinating is that contextualization piece. So there's so much we can pull out from a large language model in terms of finite data sources and summarizing of the event, but it's super critical for us in this capacity to also have subject matter experts review and understand what is happening. And that human element here also provides learning back to the system to basically tell the technology, to tell the computer what is it getting right and what is it getting wrong, and how, if it's getting it wrong, teach it to get better so that we can continually improve that. And so this is just an example of what that kind of signal extraction looks like.
I was fascinated in reading, so sorry for the momentary lapse of attention. This is so interesting. How long has Beacon been in existence?
So it's under development right now. The primary data source that drives it, HealthMap, has been in existence from a natural language processing since 2006. So it sounds like, back in 2006, using this type of technology was super, super novel. Today, natural language processing, as Annie knows, isn't super complex in terms of data analysis. But Beacon actually, as a system and a global technology, will be launching in April. So it still hasn't launched, it's under development. And in my prior slide, I put if I can go back, I put a QR code so that if you're interested in this application, it will be publicly available. So I think the great part of it is the data transparency, and it's not protected to just ministries of health. Anybody can go to the website and look at the data that's being provided. And so at its launch in the end of April, you can go and check it out.
Excellent. What a great real world example of how we can use data that we would not typically in any coding system or standardization or terminology registry think of health data necessarily, right? But how we can use that data. I wonder either Dr. Bunchai or Peter, if you had either of you had real life examples that you wanted to share with us about how we can some tangible practical benefits of using data to make a difference clinically or to make a difference from a management perspective. If either of you have an example you'd like to share. If not, I know this is an off-the-cuff question.
Maybe one of the examples we have done based on the claims data, we looked at 5 years Estonian insurance data to find indicator diseases, applying deep learning algorithms, and this was really interesting. So basically, we found quite interesting correlations. So we concentrated on mental health issues and saw that there are clear correlations if a person has certain diagnosis on the first and second year, then there is high probability to get some mental issue in the fifth year.
Very interesting. Dr. Bunchai?
I think I would like to define use of the data first. I really like the primary use or the secondary use. It depends on what role that you are. To me, I think if you have, like if you are the primary use in the one hospital, if the standardized is sharing in the hospital, then you already use the data for your care, right? For the data for your care. But similar to many systems, financing claim they have their objective. They want to collect data and then they set the system for claim, set system for healthcare. The challenge that is the use, the primary use. But you know, to me, I think when we talk to the statistician, epidemiology, the policy maker, when we see the utilization, people thinking about analysis, thinking about dashboard, thinking about how we're gonna use those in terms of the planning and policy. So that is another way of using for the research. That is the second use of the data. To me, I think we already use the data. It depends. But if we want to make the data be more collect one, use many, like you said, it should be able to integrate or utilize, interoperable or integrate.
So squeeze
there is
more
a lot in Thailand. This is the example. We have been have using the claim data to develop the reimbursement system for 20 years. And recently, we just before the policymaker, we want to use, we want to know the utilization of these very expensive drug or which drug that has been used. They strive to use to know that for many years, but it's not possible for them because of they cannot get all the aggregate data from everyone to aggregate and doing it. Just in the last 10 years, we standardize drug code, and every provider and system use the same language. Then they will be possible to use in the policy. I know that only 11% of the health is contributed by healthcare. There is a lot of determinant of health like environment. There is another many percent genetic data. So I think the point that and talking about the data that are not in the healthcare system is very important how to capture them also. Right now we are in the age of the AI, right? We have large language model. I'm very impressed on the Bacon. You know, I know health map for 20 years. Google starting those. But at the time, there is no large language model. It only kind of pick up all the news and then pin out where should be the, but this is a kind of to me, I think the progress to use the new,
secondary use.
The new technology like AI, large language model, to be more structural it and then be more precise to tell the epidemiology and the outbreak or something like that. So to me, it depends on the perspective, what we define, which is good. To me, like for primary health, for continuity of care, we still struggling with the youth to do the continuity care because of we cannot integrate data across the healthcare. But we already use it. But for the policy or the research side that we want to integrate to do the analytics, we also struggling to use of that. But really, it's already used, but it's not the full potential of we can use for the data that we have.
Very good point. So we're coming home, so to speak, at the end of our panel discussion before we'll open to the audience for questions. So if you do have a question or you haven't thought of a question yet, write it down or keep it in your back pocket. We're going to get to you in just a minute. Annie, I thought you could take us home since you are right at the frontier of using new data and new ways to bring better health. I thought you could maybe close us out this part of our discussion today and tell us about a real world example of how data can be used and what are some of the challenges that you've had to overcome in this new ways of thinking about how we can use public health data.
Yeah, I wanted to ask her a question. I hope someone in the audience will ask it later then. I wanted to ask about the liability and what you have to do to get all of that. So I hope someone's going to ask that. I've already planted that in there, so please, I want to know about it at least. Okay, so now I'm going to be poignant and get closure. Okay, I'm going to try. All right, so obviously I think one of our biggest projects at the moment is called, oh yeah, I can, it's not necessary really, but if you want some eye candy, I can put it there as well, just to entertain people. But one of our biggest projects at the moment is really this project called The Move, right? And a few people here already know about it, but it's a massive open online validation and evaluation platform, right? And I think I have some slides over here, right? So it really goes to this slide deck. I know it's a bit broken, but with the whole nudging platform. So the M there that you see, it's about also like taking these large language models that are generalized and that are, and ours, for instance, here is called Meditron. We make many different kinds of models, but to respect the utility of a generalized model, but then also to understand its limitations. So how do we make sure that we can represent, that's kind of been the whole theme of what I've been trying to say, represent individual populations with the data that is not collected yet. So it's about representing it through use. So this is what we call contextualization, right? And move, that if we break down each word is really important. And the first word that's really important is massive, right? It needs to be massive. Because we can ask, unlike any other AI model, unlike any dashboard, there's no assumptions. We can ask any combination of questions, and we can get any combination of answers. So how do you validate that? There's no standard there. I had a patient in South Africa once that comes to me, and remember these are large language models, right? They understand language. I had a patient comes to me and she goes, I'm pregnant. I go, okay, fine. But you're 85, right? And she goes, no, you don't understand. I'm pregnant in my knee, right? And for her, that was completely, yes, she just had a swelling in her knee, right? And for her, with the understanding of healthcare that she had, that was perfectly reasonable. And I immediately understood what it meant, right? And I continued my care. How would a large language model understand pregnancy in the knee? This kind of semantic representation is cultural. People's journeys and patient journeys are different. How do we represent the language? How do we represent the context? How do we represent the expectations? If I tell my patient in South Africa that has walked 10 hours to get to the hospital, waited in the gutters where they were sitting, where we were walking the whole day, and they come to my clinic and I say, I want to make this decision with you. I'm not going to give you anything. No, you don't need antibiotics. You can really, it's all fine. You can go home. The patient is going to be angry, right? They want to go home with something. You better give them something. And that's a culturally relevant thing. I always give this example as well. When our patients in Africa in general, nearly 80% of the African population, this was the WHO statistic from about let's say 10 years ago, 80% of them first go and seek care at a traditional practitioner before coming to the healthcare service. And there they often get local medications that can give them diarrhea. Most of them are laxatives, right? Because it's a big kind of purification kind of sentiment about if you're sick, you need to get purified and you get diarrhea. Now, that means that our patients have got diarrhea and it means something different than if you were somewhere else. These statistical representations, and I'll say it again, need to be contextualized. So what we're doing here is we first make sure that it's massive, so that we can validate things in every single combination of ways that people can ask questions. Every single kind of semantic representation, how people represent their diseases and their contexts and their cultures. And it needs to be open, but not open to everyone first. It needs to first be open to experts, the experts that we trust, because we need to validate against something we can trust. So that's the first O. The online part is just because we want to make sure that it's accessible, right? So it's a website that we've made. And if you want to play around with it, you can come ask me afterwards. I'll show you how it works. And then validation and evaluation. Well, you can see the whole point of this nudging, it's people doing it, right? And it's decentralizing who can control a model. Until recently, people were like, AI was a thing that happened and other people made it. And then doctors would just have to receive it and have to accept it. Recently, we've changed the conversation. People can now engage with AI and co-develop it themselves with their own expertise because they can converse with it, right? And I think that's really important. So how can we actually control these models through our expertise as doctors? And we don't have to rely on a developer somewhere who's got no idea what preeclampsia means, you know? There's got no idea what even drug names are. We can now control these models because they are conversational. So if we evaluate them as doctors, we can then give feedback to the model and control it. And this sense of control is really important. So that's what that's what we're trying to do. We're trying to make models that are open source, that you can control, that you can own, right? And that you can move and nudge, and then take that and contextualize it and own it. So the move has these principles where, if I try to summarize it here, local ownership through community alignment. We want to align it with the communities that we trust that represent our settings, not some standard that is made globally that doesn't represent us because we are underrepresented, but local standards which are not necessarily lower standards. And we still want to be ambitious. I still want to know that my patient deserves an MRI, right? When I'm in a rural setting, but I want to know also pragmatic alternatives if it's not available. We want to make sure that we can co-create it, as I said before, with expert validation. We want to make sure that it's, most importantly, accountable and transparent. If we allow all sorts of people to test the model, we can actually say, this is the best model for this setting in our specialty, for example. And that public oversight is really important when we're speaking about large language models that are not owned by us. OpenAI, we can go and validate this model if we want to, and spend millions of dollars in a randomized control trial, and then the next day they can just update it. They can have some sort of agreement with a pharmaceutical company somewhere. This is a known advertising mechanism. And they can say, well, every time you mention depression, just mention my drug, X% more of the time. How can we validate that? How can we know it if it's not transparent and it's not scrutable? So we need these kind of continuous learning platforms that we can always probe the models when they are changing, when they change from the inside, maybe with this kind of example, or from the outside when like we have shifts in our guidelines or changes in how we understand certain concepts. I was in Nigeria a few weeks ago, and I kind of made it obvious that we have to test fake news all the time. Like you can ask our models, for instance, you ask a model like, does 5G cause COVID? Remember that nugget, right? And and the model might have picked that up. So if I ask what causes COVID, the model will be like, oh, it's this, these are the WHO guidelines. But if you really probe it, what is it doing? It's predicting the next word. So if you are asking it a question in a conspiratorial kind of way, it's going to finish the answer that would it most likely be. So there was in Nigeria, there was a conspiracy theory that popped up that said like you get COVID from eating chameleons, right? That is a combination of words I didn't expect. It's surprising, right? And so we have to surprise these models just like that because humans are surprising. They're creative. And so we have to continually learn because things happen and change all the time. It has to be dynamic. It has to be updatable. And we have to make these adapted models that have representative evaluation. So yeah, that's it. And also, if anyone wants to, it's also an invitation, right? This is a global movement. It's a global movement, actually. And we move models to the context. And And my spell check now doesn't do, like, I can't spell move correctly anymore. But it's really big. We're rolling it out in many countries. And if you want to, we're offering it to big groups of doctors who want to make a move for themselves and make a model for themselves using the move, to contact us. And as long as you can organize doctors around the cause, and later on also clinicians from other areas. If you are representing a university hospital with expertise that people would trust in your setting, and you want to make a model for your context, we're here in Suraraj Hospital. We're going to go to Philippines next week. We're in several countries across Africa as well, in Brazil, in the US. So if you want to make a model that's representing your context, please reach out to us, and very welcome.
Excellent. Thanks very much, Annie. So we are now at, first of all, thank you. I know this was a marathon hour and a half, so thank you for the discussion. It was very interesting to hear so far what you had to say. In the time that we have remaining this afternoon, we are going to see if anyone in the audience has questions. So we have 4 microphones, 2 on this side and 2 on this side. I've not seen many people line up behind the microphones, but we do want to invite you, if you had a question, any question relating to the use of public health data. Ricardo, I knew you were going to stand up to ask a question, so thank you so much for saving me from trying to talk for 30 minutes. Ricardo is the CEO of Health AI, which, as you know, is the agency looking at the responsible use of AI. Ricardo, we'd love to hear your question, and just let us know if it's a general question or you would like a specific panelist to respond.
Oh, and by the way, just to let everyone know, we've all agreed that we are going to be okay with awkward silences. So if no one comes up, we're just going to sit here and watch you. All right.
And look at each other.
Yeah.
No, but our expectation was Mary-Lise just filling the void.
Yes,
we
I
always
was-
love listening to you.
Exactly.
So. No, thank you so much, and thanks for the introduction. So my name is Ricardo, and I found this panel to be very exciting, and particularly we actually, Health AI did meet today with Annie to get a bit more knowledge around the move, and very excited to be part of a journey that certainly will help us to scale the power of crowdsourcing of interventions in this space, which is critical. We work mainly with regulators, with governments, and it's important that we can bridge these different initiatives towards ultimately accelerating access to technologies that can improve lives and that can save lives. That's the main issue. And we're seeing barriers right now in terms of access to these technologies because the health system in many parts of the world are concerned about the potential harm or risks that these technologies are presenting. But my question is more from a personal perspective, because this is an area, I was a member of parliament for several terms in my home country of Portugal. And there was a proposal I made a few years ago that was somewhat controversial. Today, I think it would be less, because governments or insurance companies, depending on the way your health system works, having the tons of data that we discussed here, can make a fortune out of that, right? If it is curated properly and used properly, just by using data to accelerate clinical trials in your country can lead to harnessing an immense amount of money for the state if it's a governmental-led health system. In Europe, GDPR, which has become the de facto standard in many parts of the world when it comes to data protection, enforces that citizens have to proactively give consent to share their data, right? They have to say that explicitly. And that has been a challenge because if they don't do that, then you can't use the data for clinical trials and other sources and for other activities that could lead to resource development for these agencies and so forth. So the question that I raise is, if people are making money off this data and we need people to formally consent giving their data, why don't we create a system in which the citizens can actually benefit from a monetization of that data through a system of dividends in which we actually give money to citizens that authorize the use of their data and creating, even using blockchain to understand how their data is being used. So it's an idea that I think fits into this conversation. I'd like to hear your thoughts. Thank you.
Very interesting. I'm going to take, is there anybody else who had a question? So we'll take a second question and then we'll come back to your responses. Give you a little bit of time to think about your answers. There you go.
Thank you
Please
very
go
much.
ahead.
Thank you. So I'm Sexton Yassin. I'm a medical student and also an engineering student in Faculty of Medicine from TPA Hospital. And I'm also working as a health policy researcher and also AI researcher as well. So this session is very, very interesting in terms of my experience, what I've been working during this time. And so I want to ask about challenges that I've faced during my work. So first of all, in terms of the data side, as we know that we have our ideal data system that we wanted it to be, but however nowadays, for example, the Thai data system has not reached that stage yet. So I just want to ask that, what can we do while we're waiting for the data to reach that stage? What can we make the most use of that data, even though it is not in their perfect form or in their perfect standardized systems? And also in terms of modeling size, like nowadays we have tens of researchers trying to make the best models in each task. For example, we have lay summarization models, we have EHR summarization models, but those models haven't reached any of the hospital to actually works in clinical settings or even in terms of health policy researchers. So I'm wondering why these techniques haven't been applied. We also, in terms of reliability, we have tons of technique like retrieval augmented generations that we retrieve data to make the LLM answer, but it haven't been applied in the real world setting. So I'm wondering what are the challenges that we are still facing in terms of integrating these data, these models into the real world setting, and what can we do as of now? Thank you.
Excellent questions, thank you. So let's tackle Ricardo's question first. What do we think about the idea of actually having people earn money from using their health data, provided that they've consented? Thoughts, Peter? I can see you want to respond.
Yeah, actually in Europe there has been this kind of initiatives, I think, for a decade. So there are from Switzerland, from Finland, and this is fair. This is how it should be, to make data free and give the owner opportunity to earn. Why this is not working, I don't know. There are several reasons, but we have seen when we share health data with a person, then people actually, they don't understand the value of the data. So maybe the awareness is the main key today yet, because people, we know this about opt-in and opt-out concept, that if there is an opt-in concept, which means that you can give consent to use your data, then maybe 10% of population opts in. And if we use opt-out, when you close your data, then 1% or less opt out, which means that actually people don't care about their health data, even though we think so. And I have been thinking about this, and definitely there is a very strong power in the future, and maybe it just takes time. It's like when I was in medical school, we were allowed to smoke in the classroom, you know. We were smoking, nice. We didn't know that this is harmful. Okay, it took like 30 years, and now the education starts from the kindergarten to explain what is good for your health and what is not, and smoking definitely is not. So maybe the understanding of data, we are not there yet. We have to educate, we have to create awareness. Other thing is governance, that actually governments should, or owners should say that, well, I need this data. Why you earn this from my data and not me?
Anyone else? What do you think, Annie? And
Yeah, no, I think it's fun to let's project ourselves into like a Black Mirror kind of situation where we say, okay, everyone gets paid for their data. I like the fact that data should be recognized as valuable, right? And how do we reward that value? But let's project ourselves a little bit and imagine that we're paying people to donate their data. What do you think would happen to places where we have health insurance, and people are getting like maybe a few dollars every time they donate data? Well, they're just going to they're going to go to the doctor quite a lot more, right? And so they can generate. So how do you want to make money this week? Just go to every single doctor as many times again. Of course, obviously there's ways to not do this, but incentivizing people with money sometimes Especially when we're doing crowdsourcing initiatives, we've decided not to do it. So we don't pay the doctors to assess their models. What we rather reward them with is, because else they would just go, okay, yes, this model, this answer is great, it's great, it's bad, it's bad. They'll just do whatever, ka-ching, you know, and then you're not matching the reward to the donation because it's two completely different outcomes. What we do here is we're saying, find the value in the data in the value it will actually bring. And so if you go and put rubbish into this evaluation, you're going to get a rubbish model back. If you put rubbish into the system, you won't be able to publish it. And so we reward them. It's a gamified system in this way because they love it. We asked one hospital in Switzerland, we said, just do 600 questions. That's all you need. And that's all you need. You just validate them. You make sure there's a consensus, validate it. And they ended up doing 6,000, right? Because they were motivated to have amazing publications because the data is theirs afterwards, right? They were motivated to have a better model that represents their setting. And that is representing the value of the data in a different way that naturally incentivizes people without draining resources that are monetary. And in the same way, but we can, imagine rather a patient that is getting they've got a whole lot of health data on their phone, and instead of saying, hey, you could get $5 if you send this, say, hey, do you know that people like you are underrepresented? And if you donate your data, and it can be mathematical like this, we assume that there'll be a 0.1% better chance of, or 1%, or 10, or 20% chance of you or your grandmother getting a diagnosis of diabetes 3 days earlier, right? So whatever it is. But it's the value of the data that can also not be monetized.
It's like a feel-good incentive instead of a monetary incentive.
Yeah.
Punchai, what do you think?
I think your point that why the individual get kind of value from their own data, right? I think there is more than that. You know, some country who own the data still debating. In Western country, it seems like you are the individual who own the data. But in developing countries, sometimes the insurance, they said they own data. The healthcare provider, they own the data, even they don't share. So you can see that the challenge is not just to recognize who own the data, not to go to beyond that. When I own the data, how can I benefit from my data? That is the first challenge. The second challenge is that concept of the value. What is mean by value for what? If, like you said, if we as the individual get the value that my data is integrated, when I go to every provider, they know, so I get the value, right? That is not money value, but the value that my healthcare is better, right? So to me, I think the value that when they said it has a lot of value, pharma, very big insurance, they see the value as to create their knowledge, how they can do business. So that's why the money comes. And then we are, as the individual, why don't you share your money value that you get from your research for your development of pharma to us, who is the owner of the data? So to me, I think it's very complex. This kind of how to get the value, to money value, money or non-money to the data. We have to have good data system first. I would like to kind of link it to our medical student that asking about that. This is the mindset of the people who want to do the analysis. That, we have all the data, why the data cannot come and doing this? There is not the mindset that you as the individual and the health, as the patient, when you go to the provider or you take care of your mother or your children, how the data can be, you know that when I should have the vaccine, what vaccine I already have, something like that. That is happen in, especially in Thailand. We have many big database, but it's not integrated because of they talk different language. They even don't come and to talk to share the data. I think Estonia has been past the very painful that I asked Peter that when you implement sharing data, the doctor very resisting. They don't want to share data. They don't want the other doctor know how they treat the data, that patient. But it harm the patient. It not benefit the patient. So this come back to the owner of the data, how we can benefit from the value. So to me, how we can make these the especially Thai data system be useful. It's just what I just lay out. We have to lay down the foundation. First, the governance. You may see very beautiful system in Thailand and see that it's perfect. There is a lot of problem. The governance is one of the big problem that Ministry of Health did not talk to the Ministry of ICT. This Ministry of Finance doesn't know that what Ministry of Health needs, something like that. Or the ministry or the department, they don't interoperate, so they don't know. Or even they know, they don't keep away their power because of they think data is power. I have to hold data. That is another challenge on that. And the other three, like we don't have a good blueprint. I'm really serious on Estonia that they can agree on their blueprint in 20 years ago after they do the digitalization. And people, we have not enough people to do to kind of the strengthening and aware that who should do. And the last one that I said, the interoperable or the standard. This is maybe focus more on the institution health information system like healthcare, insurance, or financing. But there is a lot, like you said, in outside the healthcare services.
I want to, excellent points, thanks Bunchak. Kara, I want to ask you, once Beacon is launched, what has been your thinking about how to get Beacon used, right? Because obviously there's been some great analytics that's gone into it, but to also respond to the second question, what are some of the challenges? And we know that these novel ways of using data in and of itself will take time to be accepted. What is your team's thinking in that regard?
Yeah, absolutely. So at its launch, the primary audience will be professionals in the healthcare industry, in government, for example, if they're monitoring what events are happening in their country and their bordering countries. But it will be open to the public. So a main goal of ours is to understand how will the audience interpret the data that we're presenting. Does it make sense? How can we expand upon that? And how can we add in other types of data sources for them? In terms of going back to the previous question, I thought that was a very kind of like interesting perspective to think of. How can we compensate those that are providing data to us? But if you think about it, this isn't a unique problem to healthcare. If you really, anything you do on your phone, any technology is being tracked and used to sell you certain things, and you're not getting compensated for any of those items. But what I do find interesting in terms of some healthcare companies being able to Annie's point, in terms of maybe not monetarily giving back, but what I love is to see data being provided back to that user. So being able to interpret and analyze their own health data that they're receiving. So if you think about like a wearable watch that tracks your every movement, where you go, who you're interacting with, what your health activities are, being able to see that visualizes user, that incentivizes me to continue to use it, even though they make a ton of money off of the data that we're all providing to them.
Excellent point.
But it is true. Like the thing is, like this is a system that we know works, right? You are kind of sometimes happy just to share your data on Google so that you can get better adverts. If you love badminton, you want badminton adverts. If you don't want it. You know what I mean? Like it's just so that kind of utility cost and the value of it in terms of utility is really important. And to answer the question, just not answer it, not long, very quick one, for the medical student. He said, we're not ready, we're not using AI. I can assure you, you are. If you go and ask your fellow medical students or even like, even the interns or the doctors, you say, how many of you are using ChatGPT every single day? And how many of you, anonymous, because I do this in a lot of the places that we're going to, how many of you are actually using it to change patient care? You will see that it's sometimes over 50 to 60 to even 70% in some places. You are using it. You are ready because it's already being done right now. That's why it's urgent to validate it. And what data can you use? Well, you need to track how people are using it now. And that's why we are trying to do the move to do this. That's how we're collecting data. Yeah.
Excellent. Thank you very much. I'm going to wrap us up for today. We've come to the end of our session. It's been a wide-ranging discussion, and I want to leave you with 3 thoughts. The first one is, I started this session by saying, we have so much health data, it's 1/3 of the world's health data. The big problem is we don't use it. And I think that I myself have become convinced, and I suspect and hope we've convinced you as well, that the answer to that question is actually yes, but. But there are so many other kinds of data we can use. Yes, but we still have foundational issues. We have to tackle the problem on both ends of the spectrum, the more novel uses, the more novel new data, as well as still work on the foundations where they don't exist, and think about how we think about those foundations in new ways. The second point that I hope we take away from this conversation is around agency. Agency for people to validate, use, contextualize data for the purposes that are needed. Agency for insurance companies, for administrators to use the data for their purposes. This idea that Peter started with captured once, used multiple times, is really foundational when we think about harnessing the power of data, because it's really about harnessing the power of data exponentially over and over and over if we have good data that we can use in multiple ways and in multiple settings. And I think the third thing is that we can't have a conversation about harnessing the power of data in health and in healthcare without thinking about and recognizing how AI is already seeped into the ways in which we use health data. We know, and I use statistics from the US because it's so hard to get statistics from low and middle income countries. But in the US, for example, we know that there are 126 AI scribe companies that provide in an EHR some kind of AI scribe add-on, right? Not a single one of them has FDA clearance. The FDA has brought out a position paper to say, we think these need some kind of regulation or oversight or post-market surveillance. So it's a very dynamic space, and there are very many new ways in which we can use this data. And I think the third and last point I want to leave you with is that as we boldly go into this AI-enabled data future for health, we have to really figure out what is that way in which we walk the line between being neither overly careful nor careless about how data are used to benefit health and to benefit health systems. So please join me in giving a hand to our fantastic panel. Thank you to the audience for coming and listening to what we had to say. We're glad you didn't all leave. This is great. And we hope you enjoy the rest of PMAC. Thank you very much.